and welcome to Dragon Bytes, the Paediatric podcast aimed at paediatric trainees or anyone interested in child health. I'm Stacey Harris, one of the co-founders of Dragon Bytes and a paediatric trainee here in Wales. Apologies for my voice. I seem to have caught one of the respiratory viruses which comes as an occupational hazard. Or maybe it's just too much podcasting. This week we have another Reflections podcast, which has kindly been submitted by one of the trainees here in Wales. I'm so pleased to be able to share with you some more top tips, wisdom and experience on reflections from two colleagues which I feel privileged to have around me. I'll read the reflection in a rather husky voice and then hand over to Assim, the other co-founder of Dragon Bytes, to discuss around the reflection with Yvette Cloete and Lizzie Nickerson. I saw a teenager with her parents in the Community Paediatrics clinic. They had been seen previously for some concerns with social communication that had come out over the past few years. School performance had also deteriorated compared to her twin sister. The family had been seen a few months previously, and the possibility for further referral for ASD, autistic spectrum disorder, diagnosis was discussed, and the family wanted more time to think about it. I discussed the history with the patient and her parents, and then went on to talk about the possibility that we could refer for an ASD assessment. I discussed at length with the patient and her parents about what ASD is, what it means, and what effect, both positive and negative, it may have on her adult life. I also discussed that she may go for an assessment but then be deemed not to have ASD. I also discussed the fact that once the diagnostic label had been given, it could not be withdrawn if she no longer wished to have it. Describe the learning points from the case. I found this discussion very challenging, as it was mainly dealing with uncertainty. The young person was uncertain what ASD was and what positive and negative effects it would have on her. Her parents were worried that it may have a negative impact on her adolescent and adult life, but that it may open doors for further support for her. It was also challenging as the mother at one point asked me to tell her what they should do, and I couldn't give a very straight answer. I felt that as the patient was now 16, it was for her to choose whether she wanted to pursue this path. She was already planning to leave school, so additional support would be negligible for her upcoming exams. Following our consultation, the parents thanked me for my time and the advice I'd offered. I was a little surprised, as I did not feel that I had been very helpful, and I felt ill-equipped to guide them either towards or away from a referral for ASD assessment. How might you change your practice in the future? This case highlighted to me the importance of ensuring that the child or young person and their family are fully informed about any complex diagnostic process that may have both positive and negative impact on their life, and the psychological impact of being labelled with a condition. It made clear to me that there is often no rush towards these processes, and there is usually time for people to take a step back and really consider what they want to do before making a decision.
Hello and welcome to another episode of Dragon Bytes. It's Assim here, one of the presenters, and I've been joined today by Dr Yvette Cloete.
Hi, I'm Yvette.
And she's one of the General Paediatricians who works in Nevill Hall Hospital.
That's correct.
And Dr Lizzie Nickerson.
Hi, I'm Lizzie.
Hi. And you're one of our Community Paediatricians.
Yeah.
Right, lovely. So we're here today to chat about one of the reflections we've had sent in from one of our trainees. I thought we'd start off about discussing, what was good about how that reflection was written. Do you mind if we start with yourself, Lizzie?
Yeah, of course. So I thought it was a really nice narrative, actually, very nice to read, like a story, and it felt very naturally flowing and very interesting as well. I think anybody who read that would cause a lot of thoughts to go through their mind and reflect themselves. So, and I think that's one of the things that in the ARCP panels makes things interesting, because we're reading through lots and lots of assessments, and something like that can really show us that that trainee's been thinking a lot about the case. I thought it was really good as well that the trainee was thinking about competence, so Fraser competence, although they didn't, say Fraser competence. That was obviously what was going through their mind, thinking about the fact that the young person is 16, and remembering how important the young person's opinion is, which is often can be overlooked easily. And also thinking about the patient's future, talking about that she'd explored the fact that the patient wanted to leave school already, and so was presumably thinking about going into work, and that was good that she'd explored that.
Yeah, what I liked about it is I think it's really good when a reflection picks up on some important issues, and there's two really important things here that are very generalizable, and those are uncertainty in medicine, because I think that's probably one of our biggest challenges in medicine, and is often where someone starts getting to middle grade and then to consultant really struggles in having to live with sometimes you just don't know, and you think you're floundering in the dark and you have to find a way to move forward. So I think the learning from this can be generalizable to almost any situation, not just this particular case. And the other one was guiding patients. So the same thing Lizzie picked on there is that fine balance between telling a patient what to do and giving them all their information to help them make that decision. And there isn't a right or wrong there, is there? I mean, sometimes you kind of have to push the patient towards something, but you need to give them all the information. And some patients really want you to make that decision. The best I can do is what I tend to do in that situation is, well, if it was my child, this is what I would do, or I tell them a story of where it has worked or hasn't worked. If I was in this particular one, I would have used a personal example, because my son has Asperger's, and when he had the diagnosis, it's so good to know, Mummy, I'm not weird, I'm just wired differently. I think for my son, it meant a great deal to have the diagnosis. But then you have to give them the counter argument, which is put here, and obviously this is more your field of expertise, but it can cause problems as well, having that label, if it's not something you actually want to have. So I thought those were two about the choice of the reflection, very good, and then just the way it's reflected using the sort of the what now, what kind of approach, so dealing with a nice summary of what happened there, and then why it's important, what their feelings were, what the implications are for the family, and a bit of an action plan as to what they're going to do. So I thought overall a really good reflection.
I think it's interesting what you said about talking about personal examples, because I think when you first start as a trainee, you want to be very evidence-based and factual, because that's how we're taught at medical school. But actually, as time goes on and you get more experience with patients, you realise that the vast majority of patients and their families aren't really interested in evidence-based. They want to know anecdotes, they want to know about patients you've seen, and I think that takes a different spin on it, and you have to read that and change the way that you speak with those families.
Absolutely. I think it's really, a simple example is Down syndrome. I think as you continue developing as a consultant, the more life experience you have, the more stories you have to tell. And it's, I have examples of people who are adults who are now with Down syndrome who are collecting money for patients. So when a baby is there and they sort of say, oh, what's their life going to be like? I can tell them about children who've been in my cub group and various things. And it's the personal story rather than just the facts from what the textbooks say do help. And I guess that's something that's going to come with age and experience. And just being a parent, I think, has made a massive difference. I don't know if you found that, Lizzie, but being a parent, sometimes just being able to relate to the patients and say, well, yeah, I have that problem as a parent, and even though I'm a doctor, I know that's really hard for you.
Yeah, I think obviously not that, quite recently become a parent, so I remember before I had children feeling, well, I feel like I'm just as good a doctor, and I don't think it's changed me being a better doctor, but I think from the patient's point of view, they often say to you, have you got children? And that used to frustrate me before I had children, because I used to think, well, why are you asking me that? Because that's irrelevant. That doesn't change, how good or bad I am as a paediatrician. But now being able to say yes, and I've been here in this situation, it does help actually.
So the life experience kind of makes you more relatable, I suppose, doesn't it? Because it makes you as a doctor seem more human.
Yes, I guess that.
And I guess if you don't have children, because I'm not saying you've got to have children to be a good paediatrician, you can talk about your siblings or your friends' children or nephews, nieces, you can talk about anyone. I think it's just you've got to read the patient as well. It's a real skill to know what that patient wants. Some patients want the evidence, and if someone's skeptical, you kind of blast them with the evidence, don't you? Whereas some people just want the human to know what your thoughts and feelings are about it.
Yeah, I mean, it's interesting that all this stuff about life experience, because one of the impressions I got, I don't know who wrote this reflection, but I got the impression this was a very middle grade sort of reflection. So this is probably when trainees are first having to traverse that area of uncertainty that you mentioned earlier, where there probably isn't any evidence to say having a label attached to a patient is any better or worse than not having a label attached. In which case, the only way you can fill in this blank for a patient is probably through your both clinical and personal experiences.
No, absolutely, yeah. I mean, it's also finding out what the parents' agenda is. I sometimes it's a good idea, whatever the patients come in with, is what are they worried about? If they've come in with a headache, has grandpa just died from a brain tumour? Or why is it that they're really worried? You know, why have they come here? Have school sent them? It's a problem with school. Is she finding problems with socialising? Why do they want the diagnosis? What are their hopes from getting the diagnosis? Because then you can help lead them the right way as well, I think.
Yeah, definitely. I mean, I probably more of a personal opinion. I have a big issue with the word label being used about autism spectrum disorder because we're going into other areas now of the reflection, I think if somebody came and they had all the diagnostic criteria for diabetes or asthma, nobody would even be discussing whether or not you give the diagnosis. And I realise I'm coming from a very community paediatric.
Yeah, well, I'm a mother of a child with Asperger's, so I very much don't like it being called a label either.
Yeah.
So.
I mean, I think it's one thing whether the family want to then have that on the letter and take that on board and have it in their medical records, but I don't think you can argue either way if the symptomatology is there. You know, they either have a diagnosis or they don't. If they want to carry that with them through their life, that's a different debate. But so, you know, no criticism of this trainee because everybody uses that terminology, but I think you need to be careful using that terminology about neurodevelopmental conditions.
So it never even occurred to me before that using the term label might in itself be inappropriate, because if you've got the criteria, you've got the diagnosis, and there's no ifs, ands or buts about it. Well, one thing I'd like to come back to later is how you tackle these sorts of things, but just to bring us back to the reflection briefly, and the content and how it was written. Did you either of you have any thoughts about what could be done to perhaps improve the reflection, or another way that it could have been tackled that would have been nice to have seen in say an ARCP panel?
And obviously, as a previous college tutor and training program director, I've done a load of ARCP panels and probably looked at probably actually thousands of reflections, and something to make them stand out is usually quite a good thing, but I really think it's important for people's reflections to grow as they become more senior. So, you know, if an F1 or F2 and ST1 is reflecting, you probably would expect a lot of it being clinical learning. And, I saw a patient with asthma, I don't know what to do with asthma, I've read the guidelines, and this is what I'm going to do. But still make it generalizable then by saying, well, next time before I see a patient, I might look at a guideline before going in, so it's not just what I've learned about asthma, because you can't reflect about every condition you've learned about. But when you're getting to middle grade, particularly if you're getting to nearly consultant level, when you're reflecting, it's about really generalizing what you've reflected on there and thinking about system changes. So in this case, I guess it's not a particular system change they're going to do, but it's maybe identifying that dealing with uncertainty as a problem, and is there something that they can help other trainees with? Is there some reading material they can bring in, or is it something to discuss with the education lead to think about, do they need more time on that in training, in simulation? So it's trying to maybe just push it beyond just, I had this experience and I didn't know what to do. But I think just for my TPT sort of hat from previously is, don't say I'm going to do X or Y and then not evidence that, because if you have 10 different reflections like, I'm going to do a quality improvement project, I'm going to do this, I'm going to do that, and then you can't find that they've done that, then it's lip service. But a really good reflection is one that then has a reflection, they do something and then they reflect again on how that has changed, and I think that epitomizes what reflection is all about, which is learning.
I think sort of in that vein as well, it would have been nice to see some reference to looking into what support there is for the family. So what literature, maybe they looked at the National Autistic Society website or ASD Info Wales, or looking at actually what diagnostic services there are for 16-year-olds, because it gets quite complicated and different depending on where the trainee was at the time. So obviously I don't know how senior this trainee was, but I'd certainly expect that at a registrar level, and to be looking into that, so that next time the trainee was faced with a situation, they would have a whole host of resources to provide the patient with and to reference.
And then following on from that, I suppose they could then, when next faced with it, say, actually this time I had a very similar experience to this reflection I wrote 2 months ago, except I felt more armed and prepared than evidence that they've grown as a trainee.
Absolutely. So I think it's a good idea when you are reflecting, when you're going through your learning points, to in your head divide it up. So case specific. So I've gone through the asthma guideline, or I've looked up how to do what to do about diagnosing autism and what support there is. So that's very much clinical learning about that case. And then generalizable learning, dealing with uncertainty or guiding parents and what guidelines there might be, what you've looked about that. That's not specific to this case, but specific to the issues that were brought up here. And then particularly more senior system learning, changing and stopping this happening again for someone else or for yourself. So I think thinking of it in those 3 ways with every reflection you do, because there's usually something in each of those, even if it's just, well, actually I'm probably too junior to change anything here, but maybe I'll speak to my consultant. And actually, having said that, so I'm sort of, but having said that about speaking to your consultant, if you actually look through the GMC guidelines, it actually suggests that you're meant to discuss the cases you're going to reflect with your educational supervisor to really show learning. So that's not always going to work with the dynamic you have with your supervisor, but it's just a reminder for trainees that the supervisor is meant to be there. It's part of their job to lead you to improve your reflection. So if you're someone that doesn't naturally reflect and struggles with it, it's a fair expectation of your educational supervisor to spend time with you to go through your reflections and advise on how to improve them.
I suppose that's taking reflection to the next level, isn't it? So a lot of people find it fairly easy to sit down and essentially have a chat about something that's happened, but on paper. But the difficult thing is then making that constructive, and what are you going to do about improving your practice from that. And that when I do reflections, I find it quite useful to do the chat bit while I'm quite emotive about it, because then all the things that are going through my head actually genuinely come down on paper. And then when I've sort of been away from the situation for a couple of days, then come to it quite constructively with what am I going to do about it. Because I think it can be hard, especially if you're reflecting on an emotive situation, like a resuscitation, to then think constructively at that time when you're feeling quite emotive.
Oh, absolutely. And that's actually one of the points I wrote down, Lizzie. So I'm so glad you've mentioned it as well, because I think it's so important. And I've seen both extremes quite often, where people are way too emotive when they're writing their reflection, because clearly they've come home from a really bad day, whether that was a resource or a fight with a colleague or whatever, and the emotion really comes out way too clearly in the reflection, and you sometimes say things you probably shouldn't say. But equally, it can be very cold and boring if there's none of your emotion there, because we're voyeurs, aren't we? Pronounce that right. And you like to see and hear and really imagine the situation when someone's describing it. If it's too bland, it's really hard. Whereas that's what's really good here. The trainees really described very well what they were feeling and why they were uncomfortable, and I think that really shows that they have gone and thought about it. It's something that's important to them. It's not just, oh gosh, I've got to reflect, I'm going to find something to write about. It's actually something that they were really feeling about. So I often say, just write it all down in anger, but not on your portfolio, and then edit it and take it back and put it on the portfolio.
So this is the angry email that
Absolutely.
you don't send.
Absolutely. I think I've said that before, haven't I? So,
And I think other areas for improvement, it's a lovely case to reflect on ASD in girls, which often presents so differently. So that would be an idea for areas that the trainees may be going to go and read about if they don't already know about that. I thought it was interesting the trainees' use of the word a straight answer, give a straight answer to the parents. I know what they meant, but as we've already said, really, it's frequently asked, and I think people would have different opinions if you asked, a whole host of consultants about what the right thing to do is. Whether you say, yes, I think you should get a diagnosis, or no, I think you shouldn't. And I think that I find that still very difficult when patients put you on the spot. But you said you'd use your own personal experiences to sort of.
Yeah, but I'd also counter that I never want them to feel that they haven't made the final decision. But I think it's just, sometimes they really just want you to say something, and then I would just say, well, if it was my child, I would do this. In this case, I could actually say I did do it because it was my child.
Yeah.
But in some cases, you can't. I would just say, well, if I had, and you bring it back that way, so you're not actually telling them what to do, but you're saying what you would do if it was your child. So to me, that's or I guess equally, if you're not pediatric, if it's my parent or my spouse, you can always say what you would do in that situation. So to me, that's the, I guess, cop out of not saying what do this.
Yeah.
But this is what I would do. But I think it's making sure that they have all the information and the other options, so it is an informed decision. You never want a patient to not make an informed decision. But having said that, there's a group of patients that don't want to make an informed decision. They really don't want a lot of the information. They're very resistant because they don't want to hear some of those things. And it's knowing what you can get away with not telling them, but what actually ethically would be wrong not to tell them.
Yeah, it is hard, and I think if you don't give a straight answer in those words, then it just leads to more frustration, and so you can try and say, oh well, I can't make that decision for you, but this is this and this that, and I found if I've tried that in consultations, it just leads to a very frustrated family. So I think you have to try and give a straight answer as much as you can. And the other thing I was just going to mention was that the trainee said about there being no rush in these situations, and again I think that's arguable. Something that the trainee could have reflected on was the past, actually, what's happened to this young girl. She's obviously got further away from her twin, I think it mentioned, and so how long actually have the symptomatology of ASD been present, and actually would she be staying in education if it had been recognised earlier? Would she be in a different sort of emotional and mental place if it had been diagnosed earlier? So the no rush argument is, you can look at it either way, and certainly from my point of view, I would say actually most of the patients I see have been waiting so long for a diagnosis, and it's so apparent that actually there is a rush, and I do feel a sense of needing to gather everything together, because I think historically there was often an attitude of wait and watch for many years, which now that we can reflect on that, we can see that actually that's been to the detriment of many families and children.
That's really interesting, because I got the impression this family's been sort of struggling with this decision from a while. From your experiences, how would you try and get them to come to a decision a bit sooner rather than later?
Well, I think as we've already said, the family do put a lot of weight on the way you present things, and we are almost like a journalist, really, putting spin on things, and we can, whether we like it or not, we can definitely persuade patients one way or another, and we will do that whether we realise or not by our past experiences. So I know that I will be singing the praises, really, of having a diagnosis of ASD, because of so many cases that I've seen where I've seen the benefits, and so that I know that my way of speaking with a patient would be very different to somebody who maybe hasn't seen that many ASDs, because they might have a very different opinion of the diagnosis.
To me, I guess the only negative there potentially is in having the diagnosis is when people put everything down to that diagnosis in future then, and don't think that there's just natural personality traits or other reasons why someone's doing something. And but that's about the support you have afterwards. You're not getting up late in the morning isn't because you have autism, it's because you're a teenager or whatever else there might be. So that's getting, I know, once again, into personal experience with my son, is we have these conversations about, he'll say, oh, it's because I've got autism. I say, well, actually, no, that isn't autism, that's just you. I think sometimes people might not push themselves as far, do as much, because they use autism as a reason why they can't. But actually, I've never known anyone be upset. They're upset at the time of the diagnosis, but they never feel, I wish I hadn't been given the diagnosis. I've never met anyone, I don't know if you've had patients, you've had a lot more experience than me with autism. I've never come across a patient who says, I wish we weren't given the diagnosis.
No, I think I can count on one hand how many times a parent has been resistant to the diagnosis, but I would probably remember those because the school is worried about those children, and that's why we've gone through that process, because everyone around the child is very concerned and can see all the symptomatology, but for whatever reason the parent's not quite ready to see that at that time, and then obviously you have to work with the parent. But the vast majority of times when you give the diagnosis, there are tears of relief, because the parents, nobody knows a child like the mother, and they've known, really since the beginning that there's something a bit different about their child, and they're just relieved to finally hear that in those words. But what I always say when I give the diagnosis is it doesn't change, the child in front of you. So, little Matthew, who you're diagnosing, he is still Matthew. It's just that we're describing the way Matthew is. And it's not that suddenly you give the diagnosis and that patient changes into somebody else.
Yeah.
And that seems to help people, that it's nothing's changed. It's just describing what you already knew was going on with your child.
So I suppose the other thing is, did either of you have any thoughts about? Well, I mean, we've already discussed quite a few issues around what was raised during the reflection. Do you have any other thoughts about interesting aspects of this reflection?
So, just going back to the fact that this is a girl with undiagnosed ASD, just another sort of thing that would have been interesting to discuss is the mental health presentations. So we know that there are a lot of girls with undiagnosed ASD who present acutely to PDD or to CAU with deliberate self-harm or suicide attempts or depression, anxiety. We know that those are all very common presentations of undiagnosed ASD. So, it would be important to consider that in this girl, because she's high risk. And I think often when we're thinking of the acute service and the community service, we forget that there's a huge impact. If we don't recognise it in the community, then they're going to be seen acutely and fill up our wards.
Yeah. That's it. Currently working in PDD, I don't think I've ever looked at a case of deliberate self-harm or suicidal attempts, and I don't think the thought has ever occurred to me that is this a possible case of undiagnosed ASD. So in cases like that, something that might be useful for people on an acute take, what other hallmarks might you be looking for that you'd think, actually, maybe I should be referring this on to community paediatric?
Yeah, I think all trainees, ASD is a very common diagnosis, so I think all trainees should be aware of the diagnostic criteria. And I think, the way it is now with the dyad is quite simple to remember, so it's not, you don't have to remember too many criteria, but it's more difficult in girls because they're so good at masking, so it is more difficult when you've got 10 minutes to clerk them. But I think, if they're having difficulties in school, if they're having lots of issues with friends, so bullying, or mum and dad are always being called into school for reasons, then I'm sure you would look into that anyway, because you'd be thinking, well, what's going on? What is that a trigger for this? And then just having it in the back of your mind is, does this girl have social communication difficulties? Is she routine bound? Does she have any rituals? But it is harder, I'm not. It does take longer in girls, especially teenage girls, because they've had a long time to learn how to mask and how to portray themselves as excellent at social communication and interaction. And often they come to us as girls who the teachers don't like. They're unpopular. They're seen as troublemakers because they've got attitude, and that's the description that you often get. So you have to sort of delve through all of that and get underneath. And of course, if there is ASD, it will have been present since they were toddlers, at the very earliest. So you need to delve into that early history, and that's often what gives it away there.
Oh, that's really helpful, actually. Yeah, thinking of it that way around, because normally I normally approach these things from the other perspective. So they've got a diagnosis, and is that leading to their behaviour? Not, oh, they've done this. Have we missed something in the past? Though I'm sure if the clues were there, I'd have explored it. I feel like I need to defend my own practice. I'm sure I would have explored it if the clues were there. But now I think I'll be looking for those clues that little bit more.
Yeah, I mean, it's incredibly difficult in ED with all the pressures, but certainly when I did 6 months of CAMS, I was astonished by, I would say, 90% of the new patients that we saw for query depression, query anxiety, walked in the room, and it was clearly apparent that they had undiagnosed ASD, and then when they would get referred to the neurodevelopmental service.
Wow.
And speaking to the consultants I worked with at the time, they said absolutely, it's very, very common.
I think that would actually be a really good teaching topic, I think.
Yeah, I agree.
Yeah, even for consultants and registrars.
Yeah.
I mean, I think it would be really interesting to actually have a session on something like that. Because I even, I must say, it's not something that I've really thought of even that often on the ward rounds, just to explore.
Yeah.
You sort of.
I've taught myself into
Yeah, you certainly have.
I think you might have talked yourself into another podcast if I hadn't. But that's really, really helpful. Thank you. Do either of you have any top tips for trainees who are reflecting?
I think it's thinking about, the very obvious things is things changed a lot recently after the court case and that with a trainee, and it's being aware that that shouldn't stop you reflecting. You just need to maybe be a bit more sensible about how you reflect. So if you look at the GMC guidance, it is very clear that at the moment courts can ask for that. So I think make sure that you've got a good time lapse from when things have happened to when you actually put it on your portfolio, and make sure that what you put there is factual information and learning. Because if there's learning there, you can even use that reflection yourself. The GMC won't ask for it, but you can use that reflection to show that you have insight and that you've done something about learning. Because you have to reflect about every serious event. Yeah, if there's a significant event, if there's been a critical incident done about it, you need to say that on your Form R, as I'm sure you're all aware. And then to be able to be ticked off at your ARCP for your revalidation, there has to be a reflection on that. So you do need to reflect on it, and just a little tip again, make it very easy for the consultants to find when they're doing the ARCP that you have reflected on that. But it is a fine balance there, and I can understand people's nervousness about putting those cases down there. But if you keep to a very minimum on the facts, don't use it as a way to criticise or to defend yourself, but really do talk about the learning that you've made from it. That helps make you more safe. And just obviously, never use any names. Most people are very aware not to use patient names, but you do every so often see people using their colleagues' names, so avoiding that as well. And keeping it to not being it's not a case description. And I find myself something reading through the whole thing, because you just get pulled into it. As a doctor, we love to hear about patients. That's why we're doctors. We love hearing the whole detail. But that's not what reflection is about. The reflection is about the learning. So the summary needs to be just enough for everyone to know where we're at and where the learning is going to come from. But really, the emphasis needs to be on what you've learned, how you're going to change your practice from there.
I used to find it quite useful to just literally on my phone notes, if I'd been involved in an interesting case or a discussion with a colleague, literally just write a note down on my phone there and then, because I knew realistically, with shifts and everything, it probably wouldn't be for a couple of weeks before I could actually sit down and write that up. So, and then when I did finally get time to write on my portfolio, I couldn't remember any of the interesting things that had happened. So, just jotting it down there and then, so you've got a list of reflections. I used to find that useful.
That is really good, yeah. Because often you forget by the time you actually get to a computer and have half a day where you can sit down and start updating your portfolio, you've forgotten the half dozen things you've had over the last week or so that you could have reflected about.
Yeah. Absolutely.
Absolutely. I mean, the reflection doesn't go away.
Yeah.
When you're a consultant, you still have to do it as part of our master validation. You need to reflect, so that the earlier you learn how to reflect well, the better it is for you in the long term.
Yeah. I think one thing that was demonstrated really well here was that there was a sort of singular narrative that they'd picked for this reflection. Because every time you have an incident or a meeting with a patient, you've probably got dozens of different tributaries and ideas about things you could be talking about. And I've read reflections previously where they kind of talked about a dozen different things, but very superficially. Whereas this one's gone, no, I want to discuss very specifically the uncertainty about whether someone should or should not make a decision and how much I should contribute towards that. That was a very straight channel through every aspect. And I think that's really good. That'd be a really good thing for trainees to work on if they haven't done previously.
I think that is really good. And just if you have looked things up after it, put that link there, show that you actually have gone and done some reading. It just helps show that you're not just thinking about it, but you're actually trying to base it on evidence as well. So I
Yeah.
think putting the evidence down there. So I've looked at the help that is for autism, or I've looked on the guidance on uncertainty, but just put down anything you have looked at, just to and it's useful for you as well when you go back and look at your reflections. I talk to people about consultant interviews, and one of the things that's very useful there is actually have reflections available to yourself to read through before your interview, so that you can use those examples as
the
as
inevitable
something
interview
to start
questions.
something to start off with,
Yeah.
as something that went well or didn't go well, or something you're proud of, something you're upset about. So that if you have those reflections, you have a really good baseline to go on forward with. So but having the evidence there just helps you be able to check that as well again if you want to before you
Yeah.
bring that up as an example.
That's another great tip. I mean, I've never thought of using my reflections as a sort of database for future discussions. I just put them on there as like, oh, this is something that in some way changed the way I do things. But actually, as a sort of database of, I'll come back to this. This might be useful for me to think about later on.
Oh, it really will. It really, really is, because you need to have a whole cluster of things that you can use. Because when I watch people interview, you sort of see them clutch at a story, start the story, and then you can see them go, "Oh God, why have I chosen this story?" It actually doesn't show me in the best light, or I'm not really sure how I'm going to go with this to prove that. Whereas if you've read through 20 or 30 or 40 of your reflections in the hour or two before your interview, all those stories are fresh in your mind, and you can really bring them out in so many different ways. Because someone's good at interview, every single question they'll bring something from their personal practice to show, and just having that there is really useful.
Wow, excellent, fantastic.
Good tip.
Yeah.
I wish you told me that before I had a question about child protection, obviously, and I mean there were so many questions. I couldn't believe how enormous the panel was, but I just froze on that question, because even though I've seen thousands of child protection cases, I couldn't think of a really good one that gave that example. And if I'd read through my reflections, it would have been there. But I still got the job.
Well,
excellent. I'm very pleased to have you.
The only other thing I just wanted to pick up, because the trainee had said that you can't withdraw a diagnosis once it's given, and I just thought it's worth just reflecting on that, because it can be withdrawn. It isn't that that's it forever, but it is a difficult process to go through. But I don't think that should be a reason that people are then hesitant to go through the diagnostic process, for fear of not being able to withdraw a diagnosis. As we said at the beginning, if the diagnostic criteria are there, then they're there.
That's yet another really interesting point. I hadn't, now it seems so obvious now that you've said it, but that's really true, isn't it? You wouldn't think that way with any other diagnosis.
No.
If you initially thought diagnosed someone as having perhaps a form of epilepsy, and then later on it turned out that it wasn't epilepsy but perhaps a metabolic condition, that wouldn't stop you then withdrawing. So there's withdrawing the diagnosis of epilepsy. So similarly here, if evidence changes in the future.
And I think now our diagnostic process is much more rigorous, and we're much more aware of the overlap with attachment difficulties and early developmental trauma. So hopefully through that diagnostic process, those things would be picked out anyway. But certainly I have been involved in cases where the diagnosis has been changed or withdrawn, and while it's not just a visit to the clinic, it is possible to do. So I don't think it should be a fear factor in the process.
Another really good learning point for us all, well, for me anyway. And any other thoughts?
I think the one thing I really liked was a little sentence was about saying, following our consultation, the parents thanked me for my time and the advice I'd offered. I was a little surprised that I did not feel I'd been very helpful. And I think we find that so often. In the cases where you've broken your back and done so much, patients kind of will complain. And then in cases where you can hardly remember it, you get this lovely compliment or this lovely thank you. And it's just because you were a human for them, you were a person, you listened. In my clinic the other day, there was a couple of patients. I thought, well, actually I've not really done anything. My mum wasn't a doctor, my mum could probably just have sat here and had a nice little chat with you. And that's what I offered, and that's what they needed at that point. They didn't need me to wave a magic medical wand. They needed someone to listen to their problems and give them some sound advice. And it's often the patients that you do very little for, in your opinion, that actually, from the patient's perspective, you've done a lot and you've really helped them. And so we mustn't underestimate how just being human can really help help our patients.
And listening to their agenda, isn't it? You know, it might not have been on our agenda that we've done things, but actually we've completely ticked off all the things on the patient's agenda. It goes right back to what you're taught in medical school, isn't it?
Absolutely.
About the 2 agendas.
Yeah.
What's the ICE? Ideas,
Concerns,
and
expectations.
expectations.
Yeah.
If you find that out from the patient, you really are going to give them a good consult whether or not you feel that you've done the right things.
Yeah, it's also a really nice sentence to let you know, the assessors know that this patient's getting nice feedback.
Absolutely.
Because often it's quite hard to put that into your portfolio, isn't it? Because it is just a phone call to say thanks, and you feel a bit arrogant putting down in your portfolio, I got a phone call today to say thank you. You know, it's rare actually that patients write a letter that you can scan in.
Yeah.
But I think it's really important to put that sentence in, and you know, they've done it in a very humble way, which is very sweet. But you know, it tells a lot about that training.
Yeah, absolutely. And I agree. I think we've all been in that situation where we've been, you know, pleasantly surprised that someone's taken away more from a consultation than we'd expected them to. Yeah. Anyway, I think that's a really sweet note to end this chat on. So thank you very much, Yvette, and thank you very much, Lizzie.
Wow, thank you, Yvette, Lizzie and Assim. It was a pleasure to listen to you all. I have learnt loads, picked up some really useful tips, and have been inspired to write a reflection about reflecting now. Anyway, join us next week for one of our revision podcasts. Don't forget to subscribe and let others know about us, and check out our website www.dragonbytespodcast.com.